So welcome everyone. Thank you for joining. It's just past 6, so we're going to make a start. So this is our Careers in Pathology webinar series, and this is being run jointly by the Royal College of Pathologists, the University of Manchester Pathology Society, and the Pathology Division of UCL Medical Society. And we've got Penny from the Royal College of Pathologists here helping behind the scenes. So thank you, Penny. And the college, a little bit about the college. So basically, the RC Path is a membership organization representing doctors and scientists working in 17 different pathology specialties. And we'll be sharing links to our social media channels and our career pages where you can find out more after the event. And I'm Zainab. I'm the UCL Medical Pathology Chair, and we're very excited to be working on this collaborative series with the University of Manchester and RC Path. And I'm going to hand over to Rosie now, who's going to introduce herself.
Hello everyone, my name's Rosie. I'm the chair of the University of Manchester Pathology Society. We're also very excited to be working on this project to show what different careers in pathology can be like, and we're very excited for this talk.
And just about the speakers. So we've got Dr. Jessica Johnson and Dr. Rob Humphrey, and they're both chemical pathologists in their specialty training. So I'm going to hand over to Rob now to tell you a little bit about chemical pathology and his own journey.
Okay, so thank you very much, Zainab and Rosie. As they said, so my name's Rob. I'm an ST4 trainee in chemical pathology, and I work down in Oxford. So I just thought I'd start off by saying a bit about what chemical pathology is. It's a bit of a niche specialty. So on the Royal College website, they say it's the biochemical investigation of bodily fluids such as blood, urine, and cerebrospinal fluid. I kind of feel like we undersell ourselves a bit with this, and it doesn't sound like the most appealing thing. So hopefully I can show you a bit more about what the specialty entails, because it's not just that. Although that is what it is at the crux. So the way I kind of try to explain chemical pathology, because when people ask you what you do, it's quite difficult to explain. So on the left here, we've got kind of the ward doctors. So these are just our characters from Scrubs. And then on the right, we've got all the biochemical scientists who work in the lab. So from going to medical school, I know that we don't learn much about going to what happens in the lab and what's really going on there. We just get our results and assume that everything's okay. And the lab staff, so the biomedical scientists, don't necessarily know what life is like on the wards or treating patients directly. So I kind of see chemical pathology as like a bridge between these two things to make sure that kind of we can understand a bit of what goes on in the lab, so how the tests are done, kind of how the results are produced, and how reliable they are, and kind of we also understand what happens on the wards. So we this much needed bridge between the two areas sort of thing, so we can liaise with both and have a bit of an understanding about both. So just about what I'm going to talk about today. So I'll just talk about how I got into this, a bit about what the job entails, and then hopefully if we've got time we can go over a quick case. So I went to medical school and graduated in 2018 from Manchester. During medical school, I really loved the science and like the learning, but I didn't always love the clinical side. I have to say, like at school, I kind of got the grades and was good at science and just did medicine. I didn't really think about it too much. But maybe it wasn't the right choice for me. But I actually intercalated in medical biochemistry at university and really loved that. So that's kind of where I got the idea about this specialty. Then I did my foundation training after graduating, and I really struggled because I just couldn't really cope with the pressure of working on wards in the NHS. I didn't like GP, I didn't like A&E, I just knew that life wasn't for me, but I still really loved the science. And at that time, I went to a Pathology Careers Day like this one. And I also then did a chemical pathology taster week over at Liverpool. And that's when I really decided, okay, that's what I want to do. So I then applied for chemical pathology, and this is me basically every day now. because I cannot recommend it enough. Like, it suits me perfectly. And hopefully, you know, if any of that resonates with you, then maybe it could be a good specialty for you as well. So just to talk a bit about the training pathway now. So it has changed a bit. So when I applied, I finished foundation training and then went straight into run-through training. So I started as an ST1, whereas now it follows this kind of structure. So you do your medical school training, then you have to do 2 years of foundation years, and then you have to do either IMT or other things. So you can do like acute core STEM, whatever it is, acute medical training, or you can do even GP, and then you apply for ST3. So it has changed a bit. And in my opinion, that will be the biggest challenge because arguably, you know, the pressure of working in the NHS at the moment, it's quite difficult on the wards. So just a bit about kind of what the job actually entails. So why do I think it's so great? So in chemical pathology, in contrast to kind of normally on the wards, you work in a small team in chemical pathology and you generally stay in the same hospital. So you really get to know everyone who you're working with. You're not changing rotations all the time, which I find really helpful. It's a much less pressured environment. So, you know, you've not got those acute situations where you have to treat a patient immediately. You're not going to arrest calls. The pace of working is just really nice. You have time to think. So you do have time to think, but it's still interesting and challenging. So you might be confronted with cases that, you know, like electrolyte imbalances, the renal can't figure out what's going on. So they'll come to you. But the difference is, I find that, you know, we've really got the time to go away, go back to the textbooks, speak to your consultants, read some papers, and then go back with kind of a collated answer. So I just really find that a much nicer way of working. It's quite protocol driven as well. So I struggled with like the element of risk. So particularly on like GP and things, you know, you're making snap decisions quite rapidly. In the lab, you know, we have standard operating procedures for a lot of things. It's a very varied specialty. So we do clinical work, which I'll go into a bit more detail about. But we also do kind of work in the lab as well. So you'll get opportunities to work with analyzers and work with the biomedical scientists. But there's also kind of a lot of management as well. So generally as a consultant chemical pathologist, you would usually be like the head of the lab, which means that you'll be managing a lot of the lab staff in terms of kind of just from a management perspective and managing rotas, this sort of thing. So that is one aspect of it. It's also very flexible, so I can work from home occasionally as well, which is quite rare in the NHS. So that's also great. And there's also lots of opportunities for research, and I'll talk a bit more about that. So they're all the good things. Some things people might want to consider with this specialty is that if you really hate basic biochemistry, so if the Krebs cycle fills you with fear and dread, then maybe it's something to reconsider. That isn't a huge part of the job, but for the exams particularly, you do kind of have to know your pathways, enzyme deficiencies, and I think having a basic bit of enjoyment of that sort of science is quite helpful. And I know that some people who really hate that stuff really struggle with the exams. Secondly, if you really hate working with data and numbers, I don't love that myself, but you will have to do an element of that. So like, for example, working out reference intervals or comparing two different types of analyzers and the results they produce. That's something that you will come across in the role. Thirdly, if you want patient contact, so we have a bit of patient contact, maybe a clinic a week, but that's not predominantly what you'll be doing. So if that's really important to you, then that's maybe something to think about. So just to talk a bit about my typical week. So honestly, when I first started this, I was like, I just have so much free time. I don't know what I'm meant to be doing. but it does kind of over time, it does get busy, but it's a different kind of busy to being in a clinical environment. So just to talk through here, on a Monday, I might do a clinic, and then I'll maybe teach medical students in the afternoon. On a Tuesday, I'll do a duty biochemist shift in the morning. And I must say as well, this is specific to where I work. It will vary depending on where you are, but just to give you an idea of what it's like for me. So Tuesday afternoon, I'll do a bit of admin work. So that could entail all sorts of different things. In terms of portfolio as well, so on a Wednesday morning, we might have allocated time. So I don't do portfolio outside of working hours, which is basically unheard of with all my friends in other specialties. So it does offer you that time that everyone should have, but we definitely do in chemical pathology. On Thursday evening in my trust, I do an evening where I'm in the hospital until 9 p.m. And then I'm on call overnight. So they might call you with things like urgent lab results, or if someone wants urgent advice about a biochemical issue. But to be honest, they're quite relaxed on calls. And then a Friday, we might have a meeting, but it's quite a relaxed day. And then in terms of the weekends, so we do one weekend a month when we're on call. But again, that will be on call from home. And the last kind of 2 weekends, I've not been called at all. Sometimes they can be a bit busier, but generally they're quite relaxed. So kind of I've spoken a bit about what the week looks like, but just to talk a bit more in detail about the different roles you'll have. So as a duty biochemist, what would you be doing for that? So the main thing that we do is be looking through a list. So the list is basically any lab results coming out that are outside of critical range. They'll come into your screen and you'll run through them. And then if there's something that you see that you're worried about, so for example, a very low sodium, you might call the ward and just say, you need to act on this urgently. And if any of you are foundation doctors or anything, you'll be used to receiving these calls and kind of just putting the phone down straight away. Sometimes they are scientists in the lab, but often that is someone like me, so a chemical pathologist or a clinical scientist. So you could actually ask them, how should I treat this? But most of the time people don't. But you can also get clinical queries as well. So, for example, anything that people might have a query about for a biochemical test, any condition that relates to, they can ask us about. So that can be quite broad. There'll be lab queries as well. So if something goes wrong in the lab, for example, we've reported loads of inaccurate results for whatever reason, they'll come to you and ask for advice about that. We might have to vet requests. So if someone has requested like a really random test for something that's unheard of, we might give them a call and just say, did you really mean to request that test, and why? In Oxford as well, we actually do work in the lab and run the xanthochromias, so the test for if someone's had a subarachnoid hemorrhage. So we actually come in at the weekends and run those samples on a spectrophotometer. So you can sometimes get involved in the lab actual analysis, but I think that's quite unique to where I work, just because that's how the setup is. In terms of clinical work, you'll do mainly outpatient clinics, but sometimes inpatient reviews as well. And then other things will just be kind of admin things like portfolio, any projects, research, teaching, and there's plenty of time to do extra stuff as well. So just to go into a bit more detail about the clinical side. So our main areas as chemical pathologists are lipids. And also now, because of the new training program, everyone does metabolic medicine as well. So you do have to do some inherited metabolic disease. So they're your rare things like phenylketonuria and other things that I never learned about in medical school. So don't be afraid if you've never heard about any of these conditions, because I didn't know anything about them. But you will have to do an element of that, but probably not long term in your career if you don't want to. Other things we might do are metabolic bone clinics, diabetes, parenteral nutrition, obesity, renal stones, anything that basically has a biochemical test that we can test for. You might see patients who have those clinical conditions. But basically, what I love about it as well is you can tailor it to your interests. So I really like lipids, so that's the route I've gone down. Other people, I know someone else who does more metabolic bone, and you can kind of tailor it to what you're interested in. So the challenges of the specialty, I would say, definitely exams. It's basically biochemistry a lot of the time, and some people really struggle with that because it's nothing like OSCEs or anything you do at medical school. It's learning a lot of new material, but you can get through them, and also there isn't that much in the way of resources to learn because it's such a small specialty. But thankfully there are kind of collaborative groups and stuff where people share information. Also learning about the analytical stuff is all new, so that's quite tough, and that's like the lab-based stuff. But you do have to have some management skills as well, so being able to lead people and lead groups. And one thing that people might consider is the fact that in the future, given that it's a small specialty, jobs don't come up that often, and you might be dictated by where a job is available as to where you go. So that's something to consider as well. Just to get a feel for kind of, in terms of the exams, these are the sorts of books we have to read. So it is quite sciencey heavy, but we don't have to read them back to front, obviously, but still just to get a feel for what you might have to look at. So extra opportunities that you can do in the role. So research. So I did a part-time master's during the first 2 years of my training. That was kind of an optional thing that I wanted to do. But that just goes to show, I had enough time alongside all my kind of mandatory stuff with work to actually study for that. And I'm currently out of program working on clinical trials as well. So there is a lot of support to do these things in the specialty because a lot of people have a research background as well. So if that's something that interests you, then this is definitely a good specialty. Other projects you could do, so as with any medical area, you can get involved in audits and QI projects, but there's also like a big opportunity to do lab projects as well. So if your lab wants to introduce a new test, you could do the work and do the analysis of new samples to work out if the machine is working properly, that sort of thing. Also, kind of clinical work, you can kind of get involved with anything as long as it vaguely comes under your remit. You can pretty much have the time to go to anything. So we work closely with endocrinology, and you can kind of go along to any of their clinics and help out if you want to. So in terms of the contribution that chemical pathology makes, so pathology results are involved in over 70% of diagnoses. So basically they are really important, and what we do is ensure that people are getting reliable results. Often on the wards, doctors will just assume that whatever result they're getting is accurate, but what our role is to kind of bridge that gap and make sure that actually, is this an appropriate test? Is it, how sensitive and specific is it for your disease, this sort of thing. And the knowledge that I've gained since doing the specialty, I wish I knew more about it when I was working on the ward, sort of thing. So it is really important to know about kind of practicing clinically. And we are definitely saving lives. You just won't get any praise. So you're not going to be, saving lives there and then. However, indirectly, we are contributing to the process. So I thought I'd just quickly run through a case. So this is basically a case of that I came across when I was duty biochemist. And just to give you a kind of feel for maybe a bit more of an exciting thing that we'd have to do. So it was the night before Christmas, and you're the duty biochemist on call. A young patient's been found unconscious at home. They've been admitted to ICU with acidosis and renal failure. and the ICU consultant calls concerned about poisoning. So this is based loosely on a case that I actually had to deal with. So what is your role in this situation? So you want to, so we usually don't speak to the patients directly in a situation like that. We kind of get the history secondhand from the consultant or medical team. So you'd ask a bit more about what's happened, how they were found, have they got a history of ingesting anything? You might look through, so you'd look through the available results. So one thing you'd learn as part of your training is how to differentiate between different types of toxins that people might have taken based on kind of routine biochemistry results. So looking at things like their kidney function or their electrolytes. And then you might be able to provide some information to that consultant and say, you know, is this actually likely to be a toxin, or could it be something else that's causing this acidosis? And at this point as well, you know, one thing that I really like about the specialty is we're not clinically responsible necessarily, so it is their decision. But you know, if I strongly suspected that this could be poison, then you could, you know, suggest that they consider treating with an antidote or something, and then direct them to kind of toxicology experts. So what you then do is maybe add on some extra tests and ask them to send some more that would help refine the diagnosis of what's going on. So if you need to, you'll call the toxicology lab. So that's specialists, basically. So you wouldn't be doing this as kind of your routine stuff, but you need to know about it. So you call the toxicology lab, ask them to process the sample urgently for whatever you think it might be. And then you'll be responsible for liaising between the lab and the clinical team and letting them know all the results. So in this case, they were worried about something called ethylene glycol. So this is found in antifreeze. And this is kind of like a classic poisoning case that we get in our exams and things. So basically, ethylene glycol can be broken down into kind of toxic metabolites. So you'll get kind of these glycolic acid and glyoxylic acid, which will cause an acidosis. And then this oxalic acid at the bottom, that will bind to calcium ions in the blood. So you might see a low calcium. And also those calcium oxalate crystals that form can then build up in the kidneys and cause like an AKI as well. And quite cool biochemistry in the way that it used to be treated was to give people alcohol, which would compete for the alcohol dehydrogenase enzyme, which acts to break down the ethylene glycol. So if you give them alcohol, you'll prevent these toxic metabolites being formed, basically. So that's just kind of a case to show you one of the more exciting things that we have to deal with. Thankfully, in this situation, they hadn't taken anything. And obviously there's a lot of other causes of acidosis, which comes under our remit as well. So yeah, if that sort of thing interests you, then it might be a good specialty for you. And if you are still interested, this could be you having a great time in your lab coat. And I'll be more than happy to answer any questions or anything anyone has.
Thank you so much, Rob. That was a really interesting presentation. And now I'm going to hand over to Jessica, who's going to tell you about herself and her journey into chemical pathology.
Hello. I'm just going to share my screen.
Yeah.
All right, success.
Yes, we can see that.
All right, so I think we've got a bit of overlap with Rob at the beginning, but we'll see how it goes. I am Dr. Jessica Johnson. I am either an ST3 or an ST5, depending on whether on how you look at it. I, like Rob, started an ST1 entry, but they have redone the curriculum, so we've transitioned across, which has bumped me up 2 years. Come on, there we go. So often the reaction when you say chemical pathologist, including amongst other histopathologists and other members of the RC path, is who are chemical pathologists? What do you do? How I like to describe ourselves as the guy in the chair. We sort of backseat drive all the other specialties, and we offer advice and guidance and and do a lot of things behind the scenes, but like the superhero support teams, we never really get any kudos or praise. But when you go through, for example, the RC Path website, where they talk about pathology is amazing. Did you know pathologists perform almost 900 million tests each year? Now, and everyone says pathologists, including RC Path mostly, they think of histopathologists. They put their pictures, they look on slides. But then you go 900 million tests a year. Are you really that many that people are looking at? So I've sort of highlighted a lot of the things that are done for chemical pathology for RC Path to be able to put this out and say, look how amazing we are. So yes, the majority of tests requested by your doctor will be interpreted by a pathologist. We go through all the abnormal results coming through the lab, a lot of the normal results coming through the lab. And we do look at a lot of monitoring and things. Chemical pathologists at the moment are the newborn blood spot screening people. Even for sickle cell, it's all done via our tests, and they are sort of piloting doing that as a genome study, but they'll still need chemical pathology to sort of correlate the results clinically. And we sort of do tumor markers and things. So yes, a lot of these are chemical pathology, even though when people think of pathology, they think of histopathology, cellular pathology. It's a bit of a sore point sometimes. So what do we actually do? So this is very similar to what Rob said. So you got sort of three streams really: duty biochemist, which is authorizing all the test results. Rob has a list. In Sheffield, we have our queues. Go through the queues, tick, tick, tick. So what are we doing? Mostly looking out for interferences and artifacts. We're adding on tests that we think might help. So for example, if you get an isolated ALT, you will add on a gamma GT to see if that ALT is from the liver, or you might and you'd add on a CK to see if that ALT is from a muscle or possibly heart. And we write comments, and so reflective testing is when we look at the results and add things on because we think it'll be useful. It's mostly I do it for hospital patients. Mostly we do it for GPs because GPs are less likely to see their results in a time in which we still have the sample in the lab. So we're just trying to help them out and make sure that they get the results that they need, so that they can actually get a diagnosis rather than just an abnormal number. Managing the lab. So we do a lot of looking after quality control, talking to clinicians when they decide what tests they want, when do they want them, if they want things to go out of hours that we don't normally do, we will arrange that if we decide that it's important enough. Well, not important enough, but like clinically urgent, because not everything needs to be done over the weekend. And also managing patients. So Rob seems to have a very clinic light schedule across in Oxford. We tend to have our chemical pathologists are doing 2 or 3 clinics a week, even the ones who are part-time. So and then clinical scientists do more of the stuff, the lab stuff. But yeah, this is sort of the same. We got lipids, metabolic bone are the 2 big ones. Inborn errors and metabolism is niche, so you don't have to do as much of it, but it is there. Diabetes and endocrine, we get we do diabetes, but it seems to be less common. Mostly that's done by diabetes these days. You do have nutrition. I've seen chemical pathologists doing things like sodium clinics. You can like hyponatremia. And then also you got, like, as you've got here, toxicology. So I spend my Mondays at the moment doing toxicology reports for post-mortem cases. I haven't quite progressed to the giving evidence in coroner's court, but that is sort of on my trajectory at the moment. What don't we do? Analyze the samples ourselves, unless you're Rob doing xanthochromias in Oxford. We interpret them. So they'll phone us up and we can look at them on the computer. I don't actually go in and run a xanthochromia ever. And then we don't do histopathology. We don't tend to look down microscopes. There are some very niche tests where you can look down a microscope at a cell culture, but you probably won't. So yeah, we don't actually generally have to deal with the urine and the blood and the stool and all the fun things. And we all thank our lucky stars, including the BMSs, that we no longer have to do fecal fats. So what does it offer? Great work-life balance. I am currently on call. I haven't been phoned during this webinar yet, but generally, yeah, the on-calls generally from home, don't have to do anything. Lots of opportunities for research. You can just sort of get peripherally involved in research. I've ended up on a couple of posters just by like pulling lab data and helping people analyze it. I've had time during my thing to learn things like how to do R. Our quality improvement projects actually do lead to quality being improved, which is always nice. I don't rotate hospitals. Sounds like Rob doesn't either. Apparently across in Manchester and Northwest, they do a lot more rotating. You get lots of time to study for exams, which is nice. And a desk. I love the idea of having a desk. I put up pictures on it as soon as I got my chemical pathology post. I was like, got pictures and like an office mug, office hat. It's very cold. It's a very cold room. I've got an office jumper. It's a very small community, so it's very nice. It's tight knit. There's like a big worldwide mailing list with lots of with clinical biochemists where people ask for help and advice and things. So what don't we do? Procedures. We don't really do procedures. We don't do CPR. You still have to do ALS because you're doing clinics. But you don't generally have to deal with someone. And if you do, and if something happens in the clinic, then you can sort of do what you want until the med-reg arrives. Recognition. I think a lot of people do have problems with that, where they're because we are sort of behind in the shadows. And a lot of people don't really think about what we are, what we want to do. And then, as I said, no one really knows what you do. It's hard to describe how exactly we are helping out in the lab. And then you start talking about the intricacies of getting the KFRE equation put into the limbs. And people just look at you and it's like the kidney failure risk equation onto the lab information management system, and they still look at you. But I still like it. So qualifications, I put here a bit more in depth than what Rob's got. So just the general, you've got to be a doctor, and then you've got to have done so IMT is the fastest, only 2 years, but then you've also got core peds, you've got GP, you've got broad-based training, which I've never heard of anyone actually doing, but apparently it's a thing. Acute care, common STEM, anesthetics, and be eligible to work in the UK. I think we're sort of targeting burnout to be, and the ST1 entry wasn't actually having very good uptake, probably due to publicity problems. So now they're targeting people, but ST3 entry does mean that you get the pay bump. And then that was feedback. We don't really do feedback for that. So I think what the main things so I ended up doing chemical pathology because I had a chemical pathologist as my educational supervisor as an F1. So I would go into lab and he'd give me a little mini tutorial every time we had an ES meeting, and he was very lovely and had lots of time. And then as at the time I wanted to do micro, and then sort of I just didn't. I went through IMT, didn't really enjoy it. I went on mat leave. I was helping my husband do things with spreadsheets. It's like I really want a data like job that's just like dealing with data, a lot of data. I've considered public health. I feel like I've now sort of dodged a bullet with public health and micro ID because that was just before COVID. And then I got chemical pathology. There was a ST1 post coming up in Sheffield. I talked to the TPD, and she was like, "Oh yeah, we'll put one out." And so I applied for that, and got that. So I didn't have to do finished bases, which was also a big relief. So what sort of things I do? So I've done a year of lipid clinics. I did a year of lipids and metabolic bones, and then I did so it's 3 to 4 months of inborn errors. Then I did nutrition. So I did TPN ward rounds. I'm just currently doing obesity clinics. I've just finished a year of diabetes clinics, where I sort of just doing 2 clinics a week for diabetes and running my own clinic lists, and learning a lot. And you have time to go on like the courses and do all the e-learning. And while I've been doing all that, I've still been working in Sheffield, doing duty biochemistry. So I'm working with my own team. So I do my duty biochemistry sessions as well. It's very flexible. Work from home on days that I'm not doing clinics and things. Get a lot of management experience because implementing things like new equations. We're currently getting a new IT system, so doing like the clinical the clinical subject matter expert for that. As I said, I'm currently doing toxicology reporting, because I'm sort of hoping that I'll end up doing toxicology as a consultant. Lipids are fine. I don't mind lipids. Inborn errors are fun, are okay as well. It sounds a lot more niche, the inborn errors, from what you've learned it's mostly just looking at their diets and things. You don't do that much, especially in adult inborn errors. They tend to be a lot more stable. So yeah, I think it's a lot of fun. It's very different. You get to have your finger in a lot of different pies. You know, everyone does blood tests, so everyone at some point probably needs some advice from you, and you just sort of need to have an idea of what all the guidelines are, where everything's going. When people ask you for tests, like generally we say yes, but sometimes it's like, but you know if you've got a high level of like of something and they want to have it daily over the weekend, and you go, but why? Because there's no way these levels are coming down to normal. You know, you're just going to keep giving them dialysis over the weekend because the half-life is not going to be fast enough, and then you can sometimes avoid having to ship a sample halfway across the country to get them done out of hours. So there's a lot of resource management. And I think there's a lot more like people skills and things probably involved than from what I get from histopathology, where it does sound like they spend a lot of time, you know, cutting up samples, working. They do MDTs and things, but we do see there's a lot of opportunity to see patients 2 or 3 clinics a week with that. You're talking with the rest of the lab staff, the lab managers, trying to get everything and run a service. So there's a lot of that, but your patients are generally outpatients, not inpatients. So even when they get admitted, they tend to be admitted under another team, and you are offering advice rather than having to run around doing everything for them, which is nice. And yeah, as a trainee, it's great. I float in and out of clinics. I think the diabetes clinic was the only one where I actually had to turn up because there was no one like to actually do the list. Generally, I'm supernumerary in everything else. So yeah, I don't think I've done a full 20 minutes, but oh yeah, I have. All right, there we go.
Thank you so much, Jessica. That was really informative and lots of detail and new information as well. So Rosie's just going to manage the Q&A now. So if you have any questions for the panelists, please put them in the Q&A and we will try our best to answer them.
I'll just share my screen. So we've already got one question, so we'll start with that. So how was it like giving evidence at coroner's court?
I haven't actually done that. As I said, I currently just write reports, which are then countersigned by the toxicologists, who are the ones who would go and do evidence if necessary. Not actually non-court. But I think it sounds like it's not too. It's generally okay from what I hear. Like most of the time, it's just explaining what's in the report. We tend to we write very protocolized reports. And so it's not. It's apparently sometimes it gets quite but the 2 toxicologists at the moment are clinical scientists, so apparently they sometimes get like snarky comments about not being a medical doctor, but they're they know a lot about, like, you know, how toxins are and what because what you measure post-mortem isn't always like that, like levels of things post-mortem. Things redistribute, they come out of fat into the blood, they degrade from the blood. So there's a lot of other things to talk about.
Thank you. And Rob, have you got anything to say about that as well?
Thankfully, I've never been to coroner's court, and I hope to keep it that way. What I'd say, I guess, generally in our specialty, there is hopefully a bit less than that, unless you're in toxicology, in which case you might do more than the average medic. But generally in our specialty, there's not much in terms of kind of going to coroners and stuff. I suppose what we might do is liaise with the police quite a bit. So we do have to do a lot of like storing samples for them, and like there's a lot of legal implications with biochemistry samples. But generally, I mean, my consultant, like I don't think either of my consultants have ever been to court, which is quite a plus, I suppose, of the specialty as well.
I should also clarify that it's most of the time the reports just get sent, right, and that you don't get called into court. Right, the toxicologists don't get called in. It's only a very small minority of the cases where they might actually get called to do it in person.
Okay, thank you. That's great. The next question we've actually got 2 questions about this. About, do you think AI will play a role in the future of chemical pathology? I don't know if Rob, you want to start, if you've got any answer to that.
Probably. I mean, where will AI not play a role, I suppose? But yeah, I suppose lab, as opposed to other medical specialties, it probably may have more of a role. I don't know loads about this. Jessica, I feel like maybe this is more your domain, with your data enthusiasm. But yeah, I'm sure it will have a role somewhere.
Yeah, I mean, people have a lot of hopes for AI. Well, one thing, we do a lot of clinics anyway, so the AI is not going to be doing that as easily, I guess. But also there a lot of it is management and resource allocation. And then it might be that AI will eventually take over the duty biochemist bit of authorizing results and reflective testing. But it's not the most exciting bit of our job, I guess. But also, like, the problem with AI is you need to validate it. You like it's very, like, at the moment it's just sort of this elusive thing where stuff goes in and stuff comes out, but you don't, like, how do you tell an AI to forget about guideline when the guideline changes? Like you get new evidence to say practice has changed. How do you know that what evidence it's using at the moment? So at the moment, I think a lot of people don't understand quite how much validation and verification goes into things that are being able to be used by lab. And at the moment, AI is not very easy to validate or verify. So I think that is going to be a problem. But I don't think it's going to be any worse than many of the other specialties, many of the other specialties. And at least we still have clinics, so we've got that going for us.
Okay, thank you. And then someone else asking, is chemical pathology also metabolic medicine, or is it a separate specialty?
Yeah, so it is now one and the same, I think. So there used to be 2 separate specialties. So Jessica and I are pure chemical pathology, but that no longer exists. So now chemical pathology is metabolic medicine. So you'll do a bit of metabolic medicine, i.e. like your inborn errors and kind of your metabolic stuff, so like endocrinology and diabetes and things. So they all come under the same specialty now, which is ST3 entry. Correct me if I said that wrong though, Jessica.
Yeah, no, I think that's metabolic medicine doesn't really exist anymore. It used to be ChemPath plus metabolic medicine together. So the ST3 entries were a metabolic medicine, and they'd do some things with RC Path. I mean, the Royal College of Physicians, and they had to have more clinics and things than we did, but now they've combined everything into one. So
okay, thank you for that. And what would you say are the main differences between chemical biochemists and then clinical scientists?
So I feel like this is a question where if someone doesn't really quite understand what's going on. So clinical biochemists include clinical scientists. Clinical scientists are people who've done a science degree. They've often also done a PhD, and then they enter the scientific training program. So they can go do clinical biochemistry, or they can do hematology, immunology. You've got clinical scientists working in like the physiologists in cardiac units. There are lots of genetics, lots of things. So, but the clinical science, so there are clinical scientists in clinical biochemistry, and while chemical pathologists and clinical scientists are both clinical biochemists, chemical pathologists have the medical degree, and we tend to do more clinics and things. Clinical scientists often do a lot more of the GT biochemistry and the lab side of verifying, validating results. Of tests, and a lot more of the a lot more in that way, but we both end up doing managerial stuff and things like that. And I think there is now like clinical scientists are getting more involved in clinics these days as well.
Okay, and Rob, would you like to add anything to that?
I think you explained it very well there. Yeah, I suppose that is the thing. So clinical biochemists generally is what you would use to describe people who've gone through the scientific route to become consultants. So they are called consultants in kind of clinical biochemistry, whereas we'd be chemical pathologists. Sometimes people call them.
I've heard of chemical pathologists going by clinical biochemists though.
Yes, exactly. Yeah. So some people.
I think we like clinical biochemists is just all of us as a big group, and the chem paths tend to be the medics. Will always be the medics, and then the clinical scientists will be the non-medics.
Yeah, exactly.
Okay, and someone's asking about what portfolio work you would suggest going through medical school to get into chemical pathology.
So I guess in terms of portfolio work, like as in extra things to then support your application, I would say generally chemical pathologists are really keen to try and help other people get into the specialty, because it is quite niche and we want good people who want to do it. So I would say get in touch with whoever's a chemical pathologist trainee or a consultant in your medical school, in the teaching hospitals there. I would say they probably have some projects that you can get involved with, any audits or kind of projects that they've got going on. You could spend some time in the lab, but generally I think there's a lot you could do, but just having an awareness of what the job entails and doing some shadowing of kind of the duty biochemist, that sort of thing, which I'm sure they would be more than happy to let you do, puts you in a great stead to then apply to the specialty, because I do think they get quite a lot of people who don't really know much about the specialty, even what it is, and haven't got much experience with it, but just see it as like a non-ward based like specialty which doesn't have medical on calls, that sort of thing. So showing that you're genuinely wanting to do this specialty and you've got some exposure to it is quite a lot in itself. But yeah, I'd say my advice would be to contact one of the trainees or consultants, because I'm sure they'll be happy to help.
Okay, thank you. And Jessica, have you got anything that you'd like to add as well?
Yeah, I would say that because it's such a small specialty, they don't tend to look so much for commitment to specialty. Well, everything has a blood test or some other test involved. So even if you if you're thinking chemical pathology versus something else, you can do both. Like if you're thinking maybe cardiology, you do something on troponins. If you're thinking maybe psych, you do something on prolactins. Like you can shove it in anywhere, really.
Yeah, I mean, you say that, to be fair, like I was on psych before I applied, so I did an audit of the monitoring for clozapine, and whether we were doing like the TFT monitoring and stuff, and that went down well at the interview. So yeah, you can turn anything into a like chemical pathology project.
Yeah, like radiology, creatinines beforehand or something. Yeah.
Okay. And is there any way of going into chemical pathology straight after foundation years?
Not anymore. Nope.
Okay. Right. Okay. And then based on that, how competitive is it to get into chemical pathology in recent times in the UK, if you know?
I haven't looked up the most recent ones. Beforehand, it wasn't very high. think up to 2 years ago when I last checked the competition ratios, they were still not very high. You can look up competitional ratios. That's generally pretty easy to look up. They release it every year, so you can look that up. But it wasn't competitive when I got in. I got into both the ST1 and an offer from ST3, and was like, I don't have places and I don't want to go to York. So
yeah, I think it used to be quite a lot more less competitive. I think from what I've heard, it's getting a bit more competitive. But I think they had like less than one competition ratios previously. Like they'd struggled to fill posts.
Yeah,
but
I think they will turn you down if they don't think that you like if they feel like if you don't really know what chemical pathology is, or you've just thrown your hat in because you want a job. You do have to sort of come across in the interview as knowing what the specialty is and actually wanting to do it.
Yeah. Okay. Thank you. And how is the relationship with other technologists and laboratory staff?
I guess with anything, like it depends where you work. In our lab, we're really lucky. Everyone gets on really well, and there's a good relationship with everyone. But I have heard of other places where that's not the case, and there can be a bit of conflict. But I suppose it's just like any working environment. I suppose, you know, even on the wards, there can be conflict with groups and things. But what I really love about it is that you're working with the same people all the time. Whereas when you're on medical specialties and stuff, you're moving every 4 months. You hardly get the chance to even know anybody. Whereas in the lab, like you actually, you know, you really get to know everyone, and you do all have to work quite closely. So I'd say generally, like it's a better environment in my experience than working on the wards in terms of like relationships.
Yeah, I mean, I've never had a problem, and I don't personally know of any people where they've had any problems. So, you know, like there can be dysfunctional departments in any sort of specialty that I know of, but like, you know, I don't think there's any friction between medics, clinical scientists. I don't know what they were trying to get at with the question, but yeah, I don't think I think it's generally a very happy specialty. I don't think I've ever come across an unhappy chemical pathologist.
Yeah, I'd second that.
Okay, that's very good to hear. And I'll start with Jessica for this one. What would you have done if you didn't do chemical pathology?
Well, we already went down the fact that I was thinking maybe micro/public health. But yeah, I don't let something there, but things were getting more competitive for both of those specialties anyway. And I feel like I really actually did dodge a bullet, because chemical pathology has been sort of everything I wanted. It's got all the data analysis and processing, sitting in an office, seeing the occasional patient, and yeah, I've really enjoyed it.
Okay, and Rob?
So I mean, I don't know, to be honest, because I was at my wit's end after foundation years. I'm just so glad that I did find chemical pathology. But I kind of planned to just go back to university, do a master's in biochemistry and see where that took me. But I knew I definitely didn't want to work on the wards. So I have no idea really, to be honest, but I probably wouldn't be GMC registered anymore. I think I would have left. So it's kept me in the NHS.
Genetics, maybe.
Yeah.
Immunology, possibly.
Yeah, I definitely.
These are options as well.
Yeah.
Sorry. Okay, so I think that's all the questions we have in the Q&A for the time being, but thank you for answering all those. That's great. So I'm just going to introduce our next talk on behalf of the Royal College, which is on haematology with Dr. Vidler, and this is on the 21st of May. It should be just as good as this talk as well, because this one was really, really good. So sign up to that. It's free, just like this one. And yeah, links will be released soon. And then also to follow the Royal College on their social media accounts. A recording of this talk should be put on the YouTube in due course. So make sure to check that out as well. But I'd just like to thank our speakers for speaking today. It's been really, really interesting to hear about your careers. So yeah, thank you.
Thank you.
Thank you.
Thank you, Ev. And thank you to everyone for attending.